Everyone, and good morning to those of you here in Australia, of course, and good evening to those in North America joining us from Canada and the US. My name is Jacob, and I'm one of the co-founders here with CAMSA, and I'm alongside my colleague, Angela. And today we're actually going to be hosting our fifth of our specialty series, and today that features neurology. And we're very, very excited to have three wonderful speakers with us today who are leading physicians in their fields, and they're going to really provide us with some greater insight into their specialty in regard to their day-to-day cases, their research, and their experiences. And so with that being said, I'll let Angela take over from here.
So joining us today, our very first speaker is Dr. Serge Gauthier. So Dr. Serge Gauthier is a professor emeritus in the departments of neurology and neurosurgery, as well as psychiatry at McGill University. And he's a leading world expert in the management and research of Alzheimer's disease. Previously, he was director of the Alzheimer's Disease Research Unit at the McGill Center for Studies in Aging, director of the McGill Center for Studies in Aging, and holder of a research chair at the Canadian Institute for Research and Health. And lastly, also a clinical investigator at staff neurologist at the Montreal Neurological Hospital and Institution. So his research interest includes etiology and treatment of Alzheimer's disease and other related diagnoses, development of consensus guidelines on approval and use of anti-dementia drugs, and rights of persons with dementia to participate in research. So one of his biggest recent publications was the 2022 World Alzheimer Report, and he was a recipient of the Prix Galien Award in 1997, and has co-authored and authored over 700 peer-reviewed articles. So his accomplishments had led him to being appointed to the Order of Canada in 2014 and the National Order of Quebec in 2017. So without further ado, please take it away, Dr. Gauthier.
Merci, Angela. Good evening to the North Americans and good morning to the Australians listening to us right now. I was given by Angela the mandate of showing an interdependence of clinical sciences, basic sciences, and public health globally on addressing the unique needs of evolving patient populations. And Alzheimer is the perfect example. Thank you, Angela. And I will explain in a few minutes how we, over the past 30, 40 years, have evolved from just a clinical diagnosis of dementia to a more etiologic approach to what is causing dementia in an individual person. We're starting to see some breakthroughs in the treatment. So it's a bit of a success story that I will explain to you. And if I can convince one or two people in the audience to go into neurology and as a specialty and maybe neurology of aging, that would be great. Let's start with Alzheimer's disease. In 1906, it was a psychiatrist in Germany, Dr. Alois Alzheimer, N of one. By the way, you can have publications with one patient, so case studies do matter. That particular lady was in her 50s and she had an unusual dementia, and Dr. Alzheimer and colleagues of his looked at her brain after she died. She had a relatively short course, which is typical now we know of early onset dementia due to familial etiology. She has a mutation, a presenilin-1 mutation. Her brain was preserved. There were slices of her brain preserved in a brain bank in Germany, and the cause of her type of Alzheimer was actually was characterized just like 20 years ago. So Dr. Alzheimer at the time was able with the optic microscope to see changes in the brain of that woman, which were thought to occur only in old people, senile dementia. And zooming forward until the late 1960s, it was thought that Alzheimer was more a disease of young people, and anybody over age 65 with dementia was called senile dementia, and vascular factors were thought to be the predominant factor. And it's only in 1984 that there was discovery that the A-beta protein buildup in the parenchyma was the main factor. It's not sufficient to cause symptoms. You also need tau pathology. So the tangles that were seen by Dr. Alzheimer with the optic microscope, the tangles were found to be made of hyperphosphorylated tau protein in 1991 or thereabout. And animal models were created. So now it's the link between clinical observations, human pathology, hard work with biochemical studies of the protein content of what you see with the microscope, and then animal models. So you try to reproduce the amyloid buildup with or without the tau, concomitant pathology. And there were also cohorts. You have one in Melbourne that's one of the best in the world. Cohorts of volunteers, most of them are over age 50. Most are healthy, they're just worried because of family history. Some have mild symptoms and others have early dementia. And in the past 10 years, these cohorts have led to major findings that what you can see with the microscope after that, you can actually see in vivo in the life of the person, even before any symptoms. You do see the amyloid buildup, the tau spread within the brain regions, and what Braque described pathologically, Braque stages 1 to 6 with tau spreading. You can now see it with the PET scans with ligands of the new generation. The other finding, besides seeing pathology in the brain, is you may find in the blood of these participants in cohorts such as the one in Melbourne, you may see changes that reflect what's going on in the brain. And we're still arguing which of the phospho-tau fragment is the key to early diagnosis or is reflective of imminent change from mild symptoms to dementia. And maybe some of these fragments will reflect response to treatment. There's also other changes in the blood that are found that are less specific, neurofibrillary neurofilaments, light chain, reflects simply loss of neurons, and it's less specific for Alzheimer's, but they're very sensitive, possibly as a response to treatment. Shifting gear, cholinergic deficit in Alzheimer's was a major finding in the 1960s 's, using brain studies in the UK. They had a truck with resources to actually go collect the brain in hospitals and immediately examine the cortex, and they found there was a reduction of cholinacetyltransferase in the cortex of persons dying with what was clinically thought to be Alzheimer's. And this was the first line of evidence that there was a reduction in ability to synthesize acetylcholine. In 1970, this was the era of levodopa treatment for Parkinson. So that's how I got started in this field of dementia. It's a psychiatrist who asked me to help with the diagnosis of people with dementia that could be Alzheimer's type, and try choline and lecithin as transmitter supplements, like L-Dopa for dopamine. It didn't work, but it was the first step in measuring changes over 3 months, 6 months clinical trial. And then we got more sophisticated. My wife and I, we actually designed a scale to measure changes in activities of daily living. And then with other psychiatrists, we developed a neuropsychiatric inventory. More recently, a psychiatrist in Calgary designed a minimal behavioral impairment checklist. So that is to say, you can get involved as clinicians with developing new measurement tools that are needed for clinical trials, but also for clinical practice. And this is one thing I would encourage you as you go through your training and maybe a fellowship, let's call it postdoctoral fellowship. Get interested in clinical trials. And if you're primarily interested in animal models, that's one way to go. But you may be interested also in developing tools that are important for trials and clinical practice. Just to finish with the treatment, cholinergic therapy is now the standard of care, donepezil-like drugs, cholinesterase inhibitors, and memantine. But there's been some success this week, just happens, with one of the monoclonal antibodies given intravenously twice a month in people who are amyloid positive as determined by spinal fluid or PET scans. The effect size is not big. It's in the order of 27% reduction of the progression, but it's nevertheless a positive, statistically significant finding. So the reduction of amyloid load in someone with symptoms is achievable. with monoclonal antibodies. It's clearly shown to happen in animal models as well as humans. The clinical correlate of that is not very big yet, but if we think now of cleaning up the brain of the excess amyloid buildup over a year with the infusions of monoclonal antibodies, you can now think of a sequence of, and adding or replacing the anti-amyloid therapy with an anti-tau therapy or an anti-inflammatory therapy, depending on the biologic profile of the individual. So lots of excitement in the field. It's a first step, but an important one. And finally, the other arm of the topic of interest for Angela was public health. And indeed, in the field of dementia at large, not just Alzheimer, but Alzheimer with strokes, mixed dementia, or vascular dementia, there's a possibility for prevention. There's been good work done, mostly epidemiologic, looking at big populations around the world. And it's clear that if you reduce the risk of stroke as you reach middle age, you're less likely to get dementia later. They say that in Ontario, by the way. What's good for the heart is good for the brain. And Dr. Heshinsky in the University of Western Ontario has indeed convinced the government of Ontario to be very proactive in preventing stroke. And we were starting to see before the pandemic a reduction of numbers in Ontario with dementia, less than predicted. So this also was found in parts of the UK and parts of Scandinavia. So reduction of risk through midlife may be a way to reduce the number of people with dementia later in life. And then in addition, you have other risk factors that have been identified more recently, ranging from decreased hearing to social isolation. Low education has been known for quite some time to be a risk factor. Lack of physical exercise is a risk factor. So some of these risk factors are modifiable. Some are not, like if you have ApoE44, it's a big genetic load, but it is possible to reduce the impact of such a genetic mutation with the environmental and lifestyle changes. So Alzheimer's disease, I would argue, is a perfect example of a field you can go into as a clinician, and you'll be part of the new revolution of personalized medicine, earlier diagnosis with biomarkers. Hopefully it will be a bit like cancer is now, various options for therapy that are disease modifying, and you still need a lot of empathy with the families and the patient. It's an 8 to 10 year course on average if you have Alzheimer's disease. Even if you, with the best drug, you still need to take care of the person's needs, the impact of diagnosis, the disclosure. You need to take care of the worries of the brothers and sisters and children because of genetic risk. You have the caregivers who have to go through difficult times of agitation and not recognizing the house, etc., in the moderate to severe stage. So if you're interested in good clinical practice and research, I argue you should all be neurologists in the field of aging. Thank you. I will have the question period, I understand.
Thank you so much for your amazing talk, Dr. Gauthier. So if anyone has questions for Dr. Gauthier, please put them in the chat and we can definitely ask them for you, or you can unmute yourself. But I can definitely start off with one question. I really enjoyed reading the World Alzheimer's Report 2022 that was written by you and many of the leading experts in the field of Alzheimer's disease. I was wondering, based on your opinion, there's a lot of difficulty with the post-diagnosis support, so life after diagnosis, navigating the treatment, care, and support. What is one of the most challenging things that you have seen patients undergo after the diagnosis?
Unfortunately, what we hear too commonly is people are told you have dementia, good luck. And there's nothing concrete being offered, which would be totally unacceptable if someone was found to have cancer or diabetes or many other chronic conditions. And this is an attitude that has to change. I think everyone who's listening today is not of that kind of doctor. We have now a new interest in giving medical students exposure to persons living with chronic illness early in their training. So we started at McGill to have in the second year a caregiver of someone with dementia to talk about her experience. And we could build on that, a more structured approach to diagnosis and post-diagnostic care. Later, maybe in fourth year, and then everybody who goes through geriatrics, neurology will have a very structured program for diagnosis and care. But the other thing is we need to have other health professionals and physicians to help families and patients. So nursing school, school of social work school, PT and OT. We also want to have exposure early in their training to families living with dementia and some patients who can talk about it. And it's not done systematically yet. And I hope this is a first opportunity to discuss this with some Australian universities, because Australia, in my mind, is at the forefront of many post-diagnostic care initiatives. And Dr. Brodati, among others, is a world legend in the care we can provide to persons with dementia and their families.
Thank you so much for answering my question. And there's a question in the chat from Andrew, and he says, thank you for that fascinating talk. Could you elaborate on the intervention that reduced the incidence of Alzheimer's in Montreal that you mentioned again?
It was in Ontario. This is a systematic effort, a health policy effort across Ontario to treat people with transient ischemic attacks very quickly, as quickly as if you had ischemic heart pain, pre-MI kind of symptoms. You should also be aggressive in the treatment of TIAs and a close follow-up of someone with carotid obstruction, etc. So a systematic effort to reduce stroke has appeared to reduce the number of people with dementia in that province. So this is clearly a way to go worldwide, especially in China, where there's a lot of risk factors that can be modified in the older and midlife population.
Yeah, thank you.
Awesome. I actually have a question myself. Thank you, Dr. Gauthier, for the wonderful talk. I know you mentioned a little bit about this week specifically some studies surfacing with those disease-modifying drugs, potential monoclonal antibody treatment. In what you know in the field, because I know acetylcholinesterase inhibitors are right now kind of the mainstay use in the treatment of Alzheimer's. Do you see monoclonal antibodies as something to kind of take over, or more to use an adjunct kind of therapy with acetylcholinesterase inhibitors?
They're quite different. They're very good question. They're very timely. They're quite different in purpose. So for symptom improvement, cognition, function, and some aspects of behavior, cholinesterase inhibitors, what are beta-amyloid are there to stay, for sure. Yeah. The new breakthrough we have this week is a reduction of amyloid correlates with some delay in progression of symptoms over a year and a half, as measured by a scale that can be used clinically. It's a 6-item kind of scale, a CDR sum of boxes. It's not a big effect. It's in the order of 27% reduction, but it's a first big step. The other good news is that we know that once you've cleared most of the amyloid out of the brain, it remains so for at least a year off the drug. That was just demonstrated with aducanumab. So in my mind, this is anti-amyloid therapy would be done for a year. If well tolerated, you've achieved a reduction of significant amount of the amyloid buildup. And in sporadic, late onset AD, that's probably all you need to do for the amyloid. Then you move on to anti-tau, anti-inflammatory, and you continue symptomatic treatments, of course. Great. So it's a sequential approach to treatment, very similar to chemotherapy.
Great. Thank you for that.
And just a quick follow-up to that question, have you noticed that certain treatments are better catered to different individuals? Because certain individuals, like of different ethnicity, different culture, for example, different age groups, have you noticed that maybe certain like treatments are better for certain like demographics group of patients?
Very appropriate question. And this is why cholinesterase inhibitors, even if they're well known, 30 years of use and side effects are well known, are still not used by many geriatricians because they're afraid that over age 90, the risks outweigh the benefits. And most of the clinical trials have been done, it's true, with younger people in their 70s. So slowing down of the heart rate can lead to falls or syncope and falls. You can increase the rate of weight loss with cholinesterase inhibitors, weight loss that occurs with age and dementia. So in reply to your question, absolutely, age does matter. You would be more careful with the use of cholinesterase inhibitors and the dose you would use in people who are very old. The other early insight I can give you is amyloid is not so important over age 90. So don't think for a minute that we will be giving the new drug we talked about this week, lecanemab, to people over age 90. No way, because their Alzheimer is different. It's a different protein at play. It's probably TDP. They've had their amyloid a very long time. Other extreme, age 40 to 50 with Alzheimer, it's a different kind of Alzheimer. It's probably driven by presenilin mutations or APP mutations. They've had this all their life since they were born. Down syndrome also. Down syndrome leads to Alzheimer over age 40. So it's a different kind of disease that will require different kind of anti-amyloid therapy, probably sustained for many, many years. So age matters. And the other factor, I'll just finish with that, to your important question, is genetic factors may matter. So ApoE4 is a special risk for getting Alzheimer at a younger age. It's also true for Parkinson. Maybe our next speaker, Dr. Silburn, will confirm that if you're ApoE4, you will get Parkinson for whatever reason, you'll get it at a younger age. That is the case for Alzheimer. If you have a head injury and you're ApoE4, it takes longer to recover. So it's not it's a common genetic variant. 5% of the population has 4 and 15% of the population has 1 copy of the 4. These are manageable risks with what we said about reduction of vascular risks and lifestyle changes.
Okay, thank you so much, Dr. Gauthier. And just a really, really quick question, just something on the top of my mind, but I was wondering what your opinion of patients who are undergoing primary age-related tauopathy and how their treatment might be different because they have more so of the neurofibrillary tangles and the degeneration in absence of amyloid beta plaque.
Exactly. Very good point indeed. We find that 10% of people we say have Alzheimer's disease based on clinical evidence are amyloid negative and tau positive and neurodegeneration positive. So they would indeed have a kind of a primary tauopathy. Some of them will evolve to progressive supranuclear palsy or variations thereof, like CBD. They don't need amyloid therapy, obviously. And we're already thinking of that 10% of people that are amyloid negative, but they look like Alzheimer. They need indeed to have their own clinical trials. And we're not sure what to call them, by the way, yet. So maybe one of you can help. It's still a contest in the world. What do you call people who have amyloid-like phenotype, but no amyloid in their brain?
Okay. Thank you so much for sharing all of your amazing experiences and all of your knowledge. We really, really appreciate you taking the time out of your day to share your pearls. Thank you.
My pleasure.
Yep. Thank you, Dr. Gauthier. So we have 2 more speakers today. Our next will be Dr. Ronald Zhu, and then finally we have Dr. Peter Silburn with us to close it off. So I will introduce our next speaker, Dr. Ronald Zhu, who's a neurologist and a general physician. He graduated from the University of Melbourne with Bachelor of Medicine, Bachelor of Surgery, and Bachelor of Medical Science. He worked at the neuropsychiatry unit at the Royal Melbourne Hospital for his research project related to cognitive function, and he completed his early medical training in Brisbane before relocating to Sydney for both general medicine and neurology advanced training. Dr. Su enjoys teaching and research. He's completed 2 master's degrees, a Master of Public Health and Master of Philosophy, with a thesis on familial form of spinal cerebellar ataxia. He spent some time at the National Institute of Health as a part of his research, and he also provides outpatient consultation services in his suite at Toowoomba Neurology and for inpatients of St. Andrew's Hospital. He also provides public services as a staff specialist neurologist at the Toowoomba-based hospital. So without further ado, Dr. Su, if you'd like to take over and share the screen, the floor is yours.
Thank you. Thank you for your kind introduction. Okay. So yeah, thanks for your invitation. I didn't expect it would be a very academic talk, and I found today, and today is Saturday and Friday in the North America, so I think it will be a more informal kind of presentation. I hope you guys don't mind. And I'm sure Professor Silburn, which is the next speaker, will speak something more academic and more smart things compared to my presentation. So I am an Australian, and I've been working in Toowoomba for 6 years now. Let me start with some introductions of myself. So this is me. I was born and raised in Hong Kong, and I completed my primary school and secondary school in Hong Kong. You can see, I don't know if you can see my mouse moving. This is me smiling happily as a kid. And then this is my very uptight face in my class photo, in my primary one. And this is me with sort of long hair. When you were young, you still have thick hair and long hair in your secondary school, but when you get older, you will lose your hair, especially when you do neurology. This is my life in Australia. I came to Melbourne to do my final year of high school and did my undergraduate medical training in University of Melbourne. And that is the start of your career. You start to meet new friends in medical school, and they will become your lifelong friends. This dude next to me is a very hardworking ophthalmologist working in Melbourne, waiting to be promoted to a professor at some stage. And then this girl here is my best friend in medical school. Without her, I may not make it today. She helped me to do assignment a lot. She's a cardiologist working in Melbourne. And then the picture on the right is the flyer that I put up at the Royal Melbourne Hospital to recruit subjects when I was doing my Bachelor of Medical Science. I spent some time in the neuropsychiatry unit at the Royal Melbourne Hospital. At the time, I was a little bit naive. I was thinking to be a psychiatrist. And once you start working, I changed my mind. And after I have my MBBS from Melbourne Uni, I went to Brisbane to finish my internship and my basic physician training. I want to share an interesting story. My first rotation was orthopedics, and you can see in this photo, I can't remember what I was doing, but the consultant was looking over my shoulder, say, Ron, your hand is shaking a little bit, maybe, should you be a surgeon? I don't know. And then there was another surgeon that really liked me and asked me to talk to him, to talk about how to get into the basic surgical training at the time. So I was excited I could be a surgeon one day. And I went to his office, sat down with a coffee, and that consultant, the first thing that he said was, hey, Ron, in the interview, these are the questions that they may ask you. But before all this, there's one thing I want you to know, you have to do in order for you to get into the training. He said, you have to get rid of your accent. And I look at him say, hey, dude, I was born and raised in Hong Kong. I don't think I will ever change my accent, and I don't want to. Then I dropped the idea to be a surgeon. and become a physician. And I passed my FRCP exam. I went to Sydney to do my general medical training and some neurology training. The photo on the right is in Calvary Hospital that I work at as part of my general medical training. I was doing palliative care at the time. The photo on the right, top corner, it was me and my study group. We were holding a letter saying that we passed the FRCP exam. We were so happy. And then there was the ID that showing that I was working at the lab at Calling Institute at Sydney. And so during my training, I was able to do some laboratory work, research at the time. And I completed my Master of Philosophy during my advanced training. Then I went to New Zealand to finish my advanced training in neurology. This is a photo that I put up at the AAN conference for my MPhil project. And this gentleman next to me become one of my good friends. He's a gastroenterologist in New Zealand. And the lady here next to me is a cardiologist now in New Zealand. And then the photo next to that is my supervisor, and another photo with another supervisor. That's the time that you build your real friendship during your training. I watched the video that sometimes last month. I think there was an orthopedic surgeon talking about the orthopedics training. I remember one point that she put up is training. During the training, you can be very isolated. But I can guarantee you that is not the case in neurology. You will have a lot of friends. You will make your lifelong friends. Then after the FRCP, I came to Toowoomba and worked in public hospital and private hospital. And your friendship, you start new friendship with different people. And you can see that big gentleman there, he was Dr. Wynn. He was in Toowoomba for like 10, 20 years. When I first came to Toowoomba, he was 72. He was waiting for someone to come to Toowoomba so he can retire. And finally, he retired 2 years ago. So let me tell you something about Toowoomba. Toowoomba is about an hour and a half west from Brisbane. Most of the time, it takes an hour and 30 minutes to drive. Sometimes maybe an hour, 20 minutes, depends on the day. It's not that far. And it is a regional city. It's not a rural city. Yeah, and life in Toowoomba is good. This is the picture that I took because Toowoomba is on the range. It is so close to the sky. When you come up to the range, the temperature will drop for like 3-4 degrees. And then I got my dream car, the Lego one, when I was in Toowoomba. So let me tell you something about the difference between working in the regional area and the big city. In general terms, pricing of the house is a big difference. I may have to pay like 3 times the price if I lived in the same kind of house in Toowoomba. Time to travel is another factor. A lot of my friends live in Melbourne, live in Sydney. They have to travel like half an hour or 45 minutes to pick up their kids, go to work, or even an hour, depends on the traffic. And in Toowoomba, it's 50 minutes everywhere. But the downside living in regional area, I did live in Sydney for 3 years and I missed the food there. And of course, if you have a wife, she will whinge about shopping. For men, it's not too much. We can buy things online. From the neurology point of view, if you work in a regional hospital, the number of neurologists will not be as many as the big hospital. For example, Auckland Hospital, they may have 20 neurologists in the hospital. Royal Brisbane, they may have 15 neurologists. But at the same time, you are a small fish in a big bowl. If you work in a big city, you will be told to do whatever they want you to do. But if you work in a regional hospital, you will have the autonomy to do what you want because they need you. They want to do. You want to start an MS clinic. The executive say, yeah, sure, why not? The other downside or difference compared to regional hospital and big hospital is you don't have a specialized clinic in the regional hospital. You will miss the opportunity to become a super specialist like Professor Silburn. He's a super specialist because he was trained in a big city, he was trained in a big hospital, and he will have all the experience for that. But in regional hospital, you will miss out because you have to see everyone and the patient cohort is different. The other difference is the support from other specialties. In those big city hospitals, you have neuroradiologists to help you to read MRI scan. You have neurosurgery to support you. That's the thing that we do not have in regional. But on the other hand, we do have very good general physician in the regional hospital because they have to do everything. And sometimes when I got a referral from a very experienced general physician, I will have a big sigh. Well, you have done everything. I don't know what I can do for you. That is the difference. Things that I like about neurology. I think neurology is real medicine because it's rely on your clinical skill a lot, especially your neurological examinations. And many neurological disorders are diagnosed based on the clinical finding. And there are a lot of disorder that will have a investigation, the investigation will be negative. So unlike renal failure, you will have elevated creatinine. Diabetes, you will have elevated HbA1c. But in neurology, that could be negative. MRI scan can be negative, or all the blood tests can be negative. Then you have to make your clinical judgment. The other good thing I like in neurology is like retirement. As I mentioned before, Dr. Wynn that I worked with before, he retired in his late mid-70s. The neurologist before him, Professor Barry Morley, he retired in his 80s. So I still have another 40 years of my career. Unlike a surgeon, you retire in your 60s because your hands start to shake or you can't stand long. But Dr. Wynn, given his body size, he can still sit in the chair and see patients. Neurology is one thing that is very important. Clinical examination is very important in neurology. I give you an example. I saw a lady in 2017. She's a young lady with some sensory changes in the left lower limb and umbilical T6 below. And when I examine her, I find a sensory level. And I say, yes, it's gonna be a spinal cord lesion. And this is the MRI scan report. Thoracic spine MRI is normal. And I was talking to myself, oh, damn, I may did the wrong thing. I may make the wrong diagnosis. And then, no, I cannot be wrong as a neurologist. So I called the radiologist, say, hey, I think I see something on the MRI scan here. And it's more obvious at the axial. You can see some T2 signal change on the right cord. I said, that must be something. So I called the radiologist, say, hey, can you look at that again, please? And the radiologist did. And they said, yeah, this artifact. I said, yeah, whatever. And he suggested to do a 3T scan. And okay, sure. And then he said on the repeat 3T scan, 3 Tesla scan, there is abnormality. He finally admitted. And then he pointed out on that repeat scan And honestly, they look the same as the first scan. So the next thing I want to briefly talk about is what's the life as a neurologist, which I like. I work 0.5 full-time equivalent in the public hospital. I work with 4 other neurologists. When I first came to Toowoomba, there were only 2 neurologists, me and Dr. Win. But now we have 3 other full-time neurologists. We have built a service, and we share the ward service. I'm on call for stroke most Wednesday and maybe 2 to 4 weekends a year. And I work part-time in private, and that is hard work. But 95% of my work are outpatients. I may have 1 or 2 inpatients in a month. On a busy day, I can see more than 20 patients in a day. I start at 8:30. I finish at 4:30 in a public day, and sometimes 6:30 or even later when I do private. In addition to that, I do medical student teaching. I work with the clinical school. And because we have enough neurologists now, we have our own department, and I became the clinical director. And I hate that because you have a lot of political stuff I have to deal with. And at the same time, I'm also doing a FATMA course. So a very brief talk about the training pathway in Australia. You finish your medical school and you did 1 year of internship. Then you do your basic physician training. Then you pass your FRCP exam. After that, you will do 2 years of core training and 1 year of non-core training. The good thing about neurology is you can do 1 year of fellowship or 2 years of fellowship locally. There are a lot of options for you to choose, or you can go overseas. There are a lot of options for you to go in UK or USA. Some people decide to do a high degree in MPhil or PhD to become a super specialist. Then you have your FRCP. It is a well-known phenomenon, neurophobia. Not only the medical student hate and scared of neurology, also the general physician and other specialists, they just hate it. But I can tell you, neurology is not that difficult. Experience will help you. My personal view, some tips for you. If you know what you want to do, that would be great. You decide early. Then you try to complete all your training requirements to become a specialist. Then focus on what you actually like. Let's say you take 10 years to finish your training. My suggestion is you finish all the training requirement for like 6-7 years. Then you spend 3 years specializing in something that you really enjoy. No one told me about that. I was just say, okay, let's do some more general medicine. Let me just do more rotation in respiratory, cardiology. I would know more. But honestly, when you become a single organ specialist, you don't really need to know about COPD or HOCM. So that is my personal view. Not all people will agree, but yeah. So thank you and good luck in your career.
Thank you so much, Dr. Su. That was a nice contrast to Dr. Gauthier and learning a little bit more about your personal experiences and the pathway and training process here in Australia. So thank you very much. We appreciate your time today.
Thank you, Dr. Su, for that. So now our next speaker is Professor Peter Silburn. He is a neurologist and a professor of clinical neuroscience at the Queensland Brain Institute in Brisbane, and a world expert in the treatment and research of Parkinson's disease. He was honoured for his significant service to medicine as a neurologist, particularly in the treatment of neurodegenerative diseases, and he was appointed as a member of the Order of Australia in 2013 Australia Day honours. He's also a founding member and a lead clinician for the Australia Pacific Centre for Neuromodulation, which is a joint initiative between the University of Queensland and St Andrew's War Memorial Hospital. Professor Silburn graduated from the University of Queensland in 1988, and he commenced training in neurology at Princess Alexandra Hospital and completed training in Oxford University at the Radcliffe Infirmary in 1995. He was subsequently the lead clinician lecturer in neurology at the University of Oxford in the United Kingdom. From Oxford, Professor Silburn went to Karolinska Institute, Stockholm, as a research fellow in the Department of Molecular Medicine. He then became a full professor in neurobiology at the University of Queensland in 2006. So without further ado, here is Professor Silburn. Thank you.
Well, thank you very much. I'd just like to see if I can get my screen up for you. And it's somewhere here, and here it comes. So I really was very keen for this talk when I was asked, and basically because I hope I can share with you some of the experiences that I had and give you a lot of self-belief when it comes to neurology. I mean, there's no way that I could possibly have predicted my career when I started. This is just not possible, because I started from a different place to many others, and basically just with your self-belief and a real interest in helping people. And I believed from the outset that I could somehow help people and wanted to. It just kept driving me all the way through. So I essentially grew up in the central coast of New South Wales on the beach. There was probably about 3 GPs at that time there. And basically with them, they were kind of the people who helped look after it. It was like living in a place where there was the policemen, the GPs and things like that. And I couldn't quite work out what I wanted to do, but my father was a roof tiler and he worked pretty hard. My mother was essentially didn't go past primary school. And I never thought that I could go to university. But then I kept just going, and I had a funny story where the trial high school certificate, which helped work out whether you could get to university or not. I got 37 out of 175 in the trial, in the science part of the trial. And my father said, I don't think you should be doing this, Pete. And the science master said, you better choose something else. But anyway, I got there and I started heading up to Newcastle to do science. And I was interested in biology from kind of a young age, I think. And then got interested in the brain there, got offered an opportunity up in Queensland. And then that went pretty well, got into medicine after science, finished a PhD off while I was doing medicine. And then it was pretty tough, but it was worthwhile in the long run. And the rest is kind of history. So where I've gone to from sitting on the beach thinking, what am I going to do with myself, to what was really interesting me and the belief that I could help people has taken us just recently here. I'm showing you, not as a braggart, but basically there's a lot of people who contributed to this. It was the first in man study of being able to remotely monitor and alter human brain function. We finished it off last year in a very short trial, and since have been able to treat patients by altering their parameters in a deep brain stimulation system. And we can come to that. Remotely, treating people in France, Japan, New Zealand, Indonesia, all from your office or your rooms. And also you could be anywhere in the world and contribute to the global issues. So we published this in Nature Scientific Reports, good journal, and it made in the popular press the top 100 inventions of 2021. A lot of these people who were behind this, they built it, if you like, and all I did was drove it. And we look back and think, well, it's a pretty cool thing to do. It's got many issues though that you need to go through, and that's why you need to have a big team. But deep brain stimulation itself, which is how we did this work, It was voted amongst neurologists to be, in the last 100 years, in the top 10 developments. There was a fellow who was absolutely famous and pivotal in developing issues associated with Parkinson's in Queen Square in London. And he thought that the two things that he saw that were the great things in his world, in the world of Parkinson's, was the discovery of levodopa and deep brain stimulation. And how we came across it and brought it back to Australia is an interesting story in its own right. But I'll show you what it can actually do. It can help people with Parkinson's and essential tremor and dystonia. And when you get involved with the surgical side of it, many of your neurological colleagues go, well, why did you want to do that for? And my professor at Oxford said, you know, Peter, I don't think you should be involved with the neurosurgeons. But because I had a belief in myself, I wasn't arrogant, I don't think. If anything, the opposite, particularly in a place like Oxford, you can't be coming from Australia and be too arrogant there. And it went well. A neurosurgical registrar came down and he said to me, oh, look, nobody wants to get involved. Would you like to get involved? I said, sure. And once you've got the bug, and I hope to share this bug with you now shortly, you can't shake it. So since the development of DBS in Parkinson's, you're placing electrodes about a 1 millimeter target in the deep brain, down past the subthalamic nuclei and down sometimes in the brainstem. You can alter the circuits, you can alter the ecosystems. So here comes Silburn from Australia, rocked over, was fortunate enough to get a fellowship from the Neurology Association of Australia to go there and finish off my training. And we started to get involved in looking at all these disorders, particularly down the bottom here. We've developed it more recently. I'll just come through, sorry, of why we wanted to do this work. And this is why we wanted to do it. These people have got a very tough condition. The fellow up here is a young man, and most people are interested in his what condition he had with his type of Parkinson's. So he had like pumps and infusions going, and he was a young onset one, about 30s. These gentlemen are in their 60s. They were on a lot of medication. And once in the operating theatre, when the neurosurgical registrar and the neurology registrar, if you like, at the time were working together, we saw this sort of thing happen. So after 17 doses of drugs, this guy came off his drugs, as did this guy. He was taking a tablet every 2.5 hours. He had multiple tablets. And the issue is this: you're watching people in the operating theatre like this. You pop it in the right spot, you find the target and turn it on, and you've taken away 10 and 15 years of drama and disaster. And you know where they're going. And as a neurologist, you can participate in this. And as a neurologist, you see all these systems changing in those conditions. And this is this young guy, went from that to this. He was able, this is him in the rehab unit, and he's going to show us his Irish Day dance. It was St. Patrick's Day, and he wanted to show us how he could do star jumps. So you can see how powerful this is, and you can contribute and you can reduce significantly the burden of care and cost of care to people around them, as well as our community. And this is him 7 years later. Another fellow, the other fellow you saw down the bottom left, with his wife in Broome on a camel. So the data shows essentially that you can change people's lives. Fantastic, because most people, as Ronald was pointing out, have this neurophobia, but neurology is about logical thinking. You're putting your observations together with knowledge, and you're logically putting them together to generate a hypothesis. That if you've got someone who's weak, you just go through the process. Is it muscle? Is it neuromuscular junction? Is it nerve, sensory nerve, motor nerve? And you try and work out which component by doing it logically. But the very interesting thing is here's what I'm showing you. As a neurologist, when you have someone during the surgery who's awake, and you can place this tiny little electrode there, you can pick up individual neurons working. And these spiky things here represent an individual neuron and some that are close by. And you can sort them from each other by their shape, which is down here. So whilst you're in someone's brain, you can see neurons talking to each other in systems. And that's a fascinating thing to be involved with. Not only are you helping, you're learning how the brain functions and talks to each other. And indeed, we published this in a big journal, Nature Neuroscience, where these electrodes are this far down in the brain, and we got people to imagine they were walking. So we saw how the human brain imagines things in structures that were never thought to be involved. You can see how, what I was saying at the outset, there's no way I could have predicted this when I was sitting on the beach thinking, well, I hope the waves are good today. But because you get a bug about something and you keep going, and if you have a strong belief in yourself that you can help people, because remember, the fundamental thing in all of medicine is just do the right thing by the patients first. So if you can help people, particularly with diseases like brain diseases, where apart from stroke, many of these things can be avoided or prevented. These things can't. So we're altering the circuits and learning about how the brain functions. We had a practicing Buddhist who was practicing his Buddhist sort of mantras and that. And we asked him to go into his trance. So we were watching his brain cells firing off. He had Parkinson's. They were firing off, and then we gave him these words, and then we saw his whole brain pattern change from multiple units, if you like, brain cells going to just a couple. So we actually observed people meditating, and we observed people thinking about doing things. And the big deal, though, is we helped him, and we helped him get off drugs, and he's now down in Byron Bay. Parkinson's gives you class 1 evidence based on, DBS, the class 1 evidence is you compare people staying on the drugs or who have DBS. Basically, you just do it sooner rather than later now and keep people off the drugs, and you take away the cardinal motor features. But Parkinson's itself is a whole brain disorder. It affects autonomic function, sensory perception, thinking, movement everyone knows about. And the guy that I was saying before who found levodopa was asked about, he won the Nobel Prize, what sort of drug would you like to find now? And he said, well, I'd like to find the drug that can teach people common sense without killing them. And I thought that was pretty sharp, because common sense is very lacking, as some of you will know. So these are the things that you can do as a neurologist. You're involved in picking the target in the brain, looking at the neurophysiology, and treating people and programming their brain after it. This is called dystonia. These two youngsters here are going down this fellow's pathway, which previously you couldn't do anything about. It was this, and to get around, he used to have to crawl on the floor, wrap a leather belt around part of his teeth and pull his head back. And we were able to help that guy. This is that young girl. She was heading in that direction 18 months after. This is a young man, 3 years after his surgery. He went from heading to that, and he was, as you saw him before, bending over, to being able to walk around in his very formative days at school. So these are kind of inspirational things, but we've moved out of just movement and we've moved down into these areas. This is Tourette's. And this young woman was basically hospitalized in a psychiatric unit for 2 years and knocked herself out with the Tourette's. Knocked herself out 50 odd times. She basically had all of these things as part of the spectrum. And we were able to get her out of the hospital situation and back home. Cost of care, burden of care, huge, but really we helped her. And we helped her going from being stuck in psychiatric institutions to getting out and getting home. This fellow had a stroke. He had a stroke, had a heart attack, was given lysis. He had a bleed in the back part of his brain. and he had this involuntary movement of this arm. And he would go down the street and whack people involuntarily. And if you live in a country town up in far north Queensland, sometimes it's not looked fondly upon and people would attack him. But we were able to actually place the electrodes in a very deep part of the brain, more thalamic. And we were able to do this. He could use the arm, he could pick cups of teas up with this is a hot tea. So the tea lady came in, fortunately, while I was there, gave him this, and you can see the reluctance because this is what he's normally like. And we stopped it like that. So we gave him his life back and her life back. This is a young child who had a mutation in the brain, and she was unable to feed, or she couldn't talk. She had feeding tubes, she had tubes elsewhere, and that was her life. That's blurred purposely, of course. That was her life. She would spend 6 months to 9 months in the hospital with basically a whole host of things, with encephalopathy and seizures and metabolic issues from continual activity like that. And this is a win. She went from there to this.
1 week today, madam.
So that was it. And the speech pathologist came along and gave her chocolate cake. It's the first time she'd had anything orally, and she got chocolate cake first up. So you can change people and you can help people in neurology. These are the circuits you can find out about whilst you're doing all this. But I think it's interesting. I mean, I take you through that to show how you can help people these days. Basically, relying on the fact that you've got to do the right thing by the patients and get something that you like. Ronald, before, he alluded to the fact that when you're thinking about what you want to do, work out what you don't want to do. That's often the easiest thing when you're going through training. But in such a logical discipline as neurology, you're putting things together with what you see, with what we know about the structure of the brain. And the great thing is you can help people almost immediately in this area that we work in. It's a winner-winner. And what we then did more recently was this. This is what's called the neurosphere. So you can be anywhere in the world now, and you can actually change people's brain function. This is on the Sunshine Coast on the beach. You could be anywhere. You could be in Charleville, you could be in Broome, you can be in the middle of Jakarta, you could be in South Africa. And that small iPad there now, you can utilize to alter all the programming that you do in the brain. The brain at the moment, the big areas are people wirelessly transmitting their thoughts into things like flight simulators. Who's going to be at the forefront of that? Well, you're not going to get too far if you haven't got neurologists involved who understand about the brain. And that is going to be such a big area when human brain-machine interfaces begin to develop at a high level. So what we did was that in the brain of patients, you place a little electrode, it comes out like a cardiac pacemaker, and it just sits under the chest, under the pecs. What you can do is you can't just watch people around the world. They have to contact you. They initiate the session. The cybersecurity, of course, is paramount. You review it, you change the parameters, and you close and get moving. So as I said, anywhere in the world you can be. This is the Maldives. The cybersecurity, though, is always important. And of course, this was looked at very closely by the FDA in America. It was looked at by what's called CE mark in Europe. And based on a study that was initially done in my kitchen, to be honest, thereafter up the Sunshine Coast, it went worldwide. And that, I think, is probably the big thing. You can contribute. And these guys all put together These are the software engineers, and software engineering combined with neurophysiology and neurology is really taking huge advancements. So what's the moral of my story? The moral of my story is that you can come from the central coast of New South Wales. You can be inspired by things like the GP. You can think to yourself, gosh, I could actually help people. And then you just keep going. And Mervyn Eadie was one of the people in the 5th year medical lecture doing neurology, and he's now 90. He was just seemed to be such approaching things in a logical fashion in neurology. When you first look at it, you go, what's going on here? But if you just follow a process that's well worn, you'll get there. And I would encourage you all now to avoid the neurophobias, because there's many things that we can do in neurology at the moment. And it really is one of the new horizons, a very strong new horizon. So I think I'll leave it there. Just to say, keep going. You know, you don't have to be a genius. I certainly didn't come to the top of my class at any stage in med school, I can tell you now, but kept going because you believed in yourself. And in life, there's probably 3 things, as Benedictine monks would say: someone to love, some work to do, and something to look forward to. And that's what neurology can bring to you, I think. And it's not just a heart doing this or the lungs doing this. It's really a very big control of the whole human race when you think about it. It's what's going on in our heads that's destroying our environment. It's what's going on in our heads that are contributing to learning about our environment and learning about ourselves and how we interact as humans. It's a very important thing. The technology, though, neurologists have to be involved, because often technology is not the problem. That's how humans use it. And I think in your generation, I hope you're inspired to do that. And I hope in your generation of digital health, you're well aware that you can live anywhere and practice neurology and practice medicine. And as Ronald was saying, it's often very rewarding outside the city. It's just that I got the bug that I wanted to work out how if I could see human imagination, and the team helped us do that. And we help. And then someone pays you. I mean, how good is that? You work hard, you learn things, you contribute to knowledge, and you can make a living. That's my bit, guys. Please ask any questions.
Thank you, Dr. Silburn, for a very interesting presentation and your time. We have a question here from Emily Reston. Her question is, seeing how unbelievably life-changing DBS seems to be as an intervention for improving quality of life, she was wondering if there are any downsides to DBS or any untoward side effects, and what are some of the current challenges facing this new horizon of progress?
Sure. I think the DBS, it's like any procedure. You have to have evidence to keep pursuing. There's no better evidence in medicine than class 1 evidence published in top tier medical journals of the world, like New England Journal of Medicine, Lancet, all of those. And as I said, it was considered to be in the top 10 of the last 100 years of development in brain work. Of course, when you're going into the brain, there's always an issue that someone can die during the anesthetic, they can have a stroke, you can just miss the target, and then you have to come out and go back down again. But with DBS, everything's reversible. You're not destroying tissue. Some procedures years ago, which have been around, you would actually lesion the area. You might hear about focused ultrasound and laser therapies and that. But that's destroying brain, and you can only really destroy brain and most of the structures on one side to actually relieve symptoms. These things, though, wouldn't be around if the adverse events of people who had DBS and the adverse events of people who stay on drugs alone, say in Parkinson's, if they weren't very similar, then it wouldn't be around. So there's many things that can happen, but in DBS, because you're placing this implantable pulse generator on the chest, you can't go diving below 80 feet because of the pressure changes, which upsets the electronics, or arc welding. It will arc into the device. It won't go into the brain, but it'll upset the electronics. You've got to take it out and put another one back in. Oh, okay. Okay. So that's what can happen. Nothing is without risk, but the big thing about the deep brain stimulation is that patients are awake for a part of it. They can't feel anything. Your brain can't feel things. You can touch it and do things to it, but you can study it. And I think that's one of the most exciting things. But I think for me, the bug came when this neurosurgical registrar, who's now the head of Oxford Neurosurgery, basically said, no one wants to do it. And then when we saw the patients change like that, you've got to be involved if they've been involved for 10 to 15 years. Anyone else? Is there any other question I missed?
Thank you. There's a few more in the chat.
Sure.
So Monica has asked, what are the main differences between neurology and neurosurgery in terms of clinical presentations and roles, other than the surgery aspect, and any tips for deciding which to pursue when one is interested in both?
Okay. I think the big thing about neurosurgery and neurology is the neurologist like to put it together and think it out, and you've got all your understanding of structures and the physiology. And neurosurgeons just like to do things, they got to do things. They get agitated when they can't do things. But this is one of the great teamwork issues here, I think, is that you work together as a neurologist and you get more out of it when you're working with a neurosurgeon. So they spend years, the neurosurgical people, doing sort of things, and they learn about spine as well as brain. And in neurology, you focus on this. And so basically, if you're doing the neurology and you've got a good understanding, you work with the neurosurgeon to make sure the neurosurgeon gets the electrode in the right place in my world, but in any sort of surgery. So if you like to get in there and cut away at things and use your hands a lot, then the surgery side is for you. They have quite a vigorous program, and a lot of people get worn out by it. And you've definitely, again, got to have the bug. In neurology, you can just keep going. You heard Ronald say before, there's people in their 80s. The neurosurgery world stopped in your probably 60s or so. You're just learning all the time. And in this team, you've got neurophysiologists, neuroanesthetists, all of that. What are the tips of getting forward? Do the right thing by the patient. That's the end of the story. And after that, if you're doing the right thing by the patient, you win. That's it.
Thank you for that one. There is another question.
Sure.
Rohitha was wondering, what are your thoughts on Neuralink or brain-machine interfaces generally?
Sure, they're two big things. Neuralink is, one of the pathways that people are pursuing, but there's many other pathways. I alluded to you before about how people can sit there thinking about something, feed into a computer, and you can actually get into a flight simulator and fly an F-35 fighter jet. And we saw something in a closed meeting, it was a very closed meeting, that kind of worried a lot of us, actually, in that a quadriplegic Afghanistan veteran was taught how to do gaming, and he had the neurosurgeons in the US in the Department of Defense had placed tiny electrodes over the whole cortex of the brain and were monitoring the thought processes and electrical activity and the neurophysiology of the brain, but did actually teach him how to, in the simulator, take off, bank around a mountain. He saw a Russian MiG jet and he fired the missile and took it out. That's a different kind of world. But it again highlights one thing, is that Neuralink's not the only way. My point is this: it's not technology that's the problem, it's how humans use it. And these technologies like artificial intelligence and brain-machine interfaces will just start to continue to increase, just as any digitalization is. I mean, digitalization, the first digitalization, if you think, was dot dash in a Morse code. And technology and how humans use things been around probably when we were sitting around in the cave, and in comes a saber-toothed tiger. And if you thought, oh, that's a nice tiger, your genes are gone. But if you had a club next to you and the tiger came, you could fight it off, you'd think that was a good thing and you saved your family and everyone was safe. but you could use the same club if your neighbor was annoying you to ward them off. So humans have always wanted to be thinking forward. What can I, initiating things, discovering things, and utilizing things. That's kind of, where it's going. Many other things besides that. In fact, there was MIT had these young kids that had to work out how you could get something to move without having a skeleton. You or I have got an endoskeleton, crabs have got an exoskeleton, muscles are attached. And these kids worked out that the octopus could move in 3 dimensions without even having a skeleton. And so they thought, biomimicry, because biology has mimicked many things that we're starting to and establish them as useful strategies, then humans are now just discovering that, is that they could work out, and they did work out a machine kind of thing that could go in 3 dimensions in different directions without having a skeleton to move. They won the MIT prize for that year. But like I say, you don't have to be a genius to be in this. You just got to be passionate and want to really learn things and do the right thing by the patients on the way.
Thank you, Professor Silburn. I believe Jake has a question for you now.
Yep. Awesome. Thank you so much. Very, very fascinating to learn about that, the technology you guys were able to develop and use and how that has applications now worldwide. Specifically, I wanted to try to tie into what our first speaker, Dr. Gauthier, said. He was mentioning how monoclonal antibodies, specifically targeting those beta amyloid plaques for Alzheimer's. I was wondering if we can kind of contrast that with Parkinson's. I know like the Lewy bodies and the alpha synuclein buildup, how that's kind of a characteristic pathophysiological part of that process. Is there, like, I understand, of course, like L-DOPA and dopamine, and antagonists and whatnot. Are there any like monoclonal antibodies or disease modifying drugs that are being, I guess, trialed or used as well in terms of treating Parkinson's, or is that more so focused with Alzheimer's research?
No, I think it's a good question. And basically, monoclonal antibodies, highly specific for proteins and other molecules. Often with alpha synuclein, it's a really important protein in synaptic transmission and taking messages through. And basically, though, it's within the cell and it sits around. When it gets around the nuclear membrane, the membrane of the nucleus, it basically gets stuck. And there's different ways of unsticking it. But you've got to get things across the blood-brain barrier. So people are using ultrasound to open it up. And there's a thing called the glymphatics. And if you've never heard of glymphatics, it's pretty new in that the brain has got like a lymphatic system run by the astrocytes. And it's when we sleep, it takes away all our extracellular metabolites. And that's why when you can, have major issues with sleep disorders. What happens is you've got to get the monoclonals in there. And if you want to get something outside the cell, it has to penetrate through the cell membrane and get there. So extracellular targets, it's not a bad idea. There's been a lot said about it. In Parkinson's, alpha synuclein is not the only problem. There are people who have PD symptoms that don't necessarily have alpha synuclein accumulation there, and don't necessarily pick up dopamine deficiencies in the brain. There will be many, many genes involved in Parkinson's. The Charcot-Marie tooth disease, there was thought to be 3 genes. Now there's like 100, there's hundreds of them about the pathway. At the moment, the molecules that look to be of interest to helping are ones that involve dismutases and copper, unraveling that, and iron. And these are big things. I think there is a study going on, which is a combined San Francisco, University of Melbourne study in multi-system atrophy, which is showing promise. But you have to be very careful that once you start to take away proteins that are clearly there for some reason, you have to be careful that you don't cause mischief later on, okay? It's like cocaine. Some people, not that I've had any experience with cocaine, but cocaine, yeah, here I'm a superhero. The world's the best place. but it knocks your brain off long term. So in Parkinson's, you've got to actually make sure that what you're putting in and trying to extract is not having a long-term effect. So that's why you're always in medicine. Try the tough diseases first, such as the synucleinopathies like multisystem atrophy. And my understanding is that drug's still going well.
Thank you, Professor Silburn.
Thank you.
Angela has a question for you now.
Yeah, sure.
Hi,
Thank you.
Dr. Silver. Thank you so much for your amazing talk. I really appreciated your time. And I have a question in terms of the application of DBS in Alzheimer's disease in alignment with the first talk by Dr. Gauthier. In your opinion, do you think that DBS could potentially be applied to some of the memory circuits in our brain to help stabilize, for example, like cognitive decline in patients undergoing degeneration?
Sure. The thing with the background answer to this, the situation we're in, is basically that DBS can, the brain's, I like to think of the brain as a neural ecosystem. You do something over here, it can affect here, you damage it, and it can structure function damage as well as connectivity. People have looked at Alzheimer's in the past, and the interesting fact there was in Canada, in Toronto, a group with Andre Lozano were operating on someone, from memory, with weight issues. Now, trying to think, how can we actually help people with resistant obesity? They placed an electrode in, it didn't quite hit where they wanted. And then when they turned it on, somebody started to get memories of when they were a child. So they were able to actually activate the memory circuit, the PAPES circuit in the brain. You can do this by different targets. Some are easier to find than others with the electrodes, but that's what happened then. But the problem is Alzheimer's is not just in that memory circuit, and you can possibly alter something. And we certainly now know that when you stimulate human brains with activity, mental activity and physical activity, you generate new cells out of neurogenesis in the temporal lobe. So when you stimulate the brain with DBS in certain circuits, you can increase neurogenesis, hippocampal volumes increase, but the rest of the brain's falling apart. So I got in a bit of trouble there many years ago because in the meeting, I just said, well, that's fantastic. You're stimulating, it's like putting the most expensive generator in the world in a condemned building. The rest of it's falling apart. But the fact is, those interesting observations are all providing a brick in the wall, you know, a brick to get the bridge across from one side of the river to the other. The circuits can be stimulated along the whole. There's different nodes. At the moment, there's probably not too much in terms of Alzheimer's, but there's a thing called Lewy body, diffuse Lewy body disease, where people will have fluctuating cognition. They can tell you about the NASDAQ index in the USA, and about an hour later, they don't even know where they are. So it fluctuates. To be able to fluctuate means the structure's not broken yet. So if anything was going to help that, diffuse Lewy body disease may be one of those things that you can help temporarily. Remember, we don't want everyone to live to 150. We want that time that we have on the planet to actually be as good as it can be. If we can even get 10 extra years out, that would be a good thing. So they've got to pick the diseases. At the moment, in Parkinson's even, what people forget is there's 13 other neurotransmitters that drop off. Everyone talks about dopamine and the substantia nigra, but the amygdala and that complex is also highly involved to the same extent as the substantia nigra. So things are picking off all over the place. And that's why I like to think of it as an ecosystem. You upset something and then somewhere else is going to drop off. And that's the sort of thing. If you can influence the circuits, good, but you need to pick the diseases that clinicians and neurologists are seeing all the time. That's how it kind of runs, I think. Yeah, it did create a bit of a fracas from the fellow from Australia who said, you've got to realise this is going into a fully condemned building. Stuck in everyone's heads, though. That's cheeky.
Yeah,
Anything else?
Thank you so much, Dr. Silburn. I don't think there are any more questions in the chat, and I think Jake and I also have had our questions answered. We wanted to thank you so much for taking the time to speak with us today and for sharing all of your great research and insight into the field of neurology.
Well, thank you for the opportunity to speak to you guys. Hopefully my aim was to try and stimulate you in two ways. One, to show you don't have to be a genius to contribute to knowledge of one of the most complex machines in the world, and that you help people. Always remember, the bottom line in medicine is to help people and do the right thing by the patients.
Yeah,
Thank you very much.
Thank you, Dr. Silburn.
Okay.
Thank you again.
See you guys.
Yeah.
And
Thank
good
you.
luck. All the best.
Thank you. Thank you, everybody, for tuning in today. This is the end of our talk for neurology, and I hope you guys join in our next specialty series in a month. Thank you so much.